Uh, Good morning, everyone. I thank ARC for giving me this opportunity. Uh, Basically, what I'm going to be talking about is my innovation, which is a software which has been entirely designed by me for LASIK planning. And it's specifically intended for the Wavelight platform and for doing Contoura LASIK. Contoura LASIK basically is a FDA approved form of topography guided LASIK, and my software mainly assists with topography guided LASIK. This software is Microsoft Excel based, and I've used mathematical algebraic formula, trigonometry, vector mathematics and all to create the software. Quickly, let me explain to you, any innovation needs a problem statement, and what was the need for me to make this software. So the problem statement here is, when I plan my topography guided LASIK cases, it's always very challenging with a lot of ambiguity. And the company recommended, percentage of patients are only 20 to 30% patients who fit the company recommendation. So for the others, we are recommended not to do topography guided LASIK, and the planning is quite time consuming. So my iSMART innovative solution is, I can do topography guided LASIK for all patients, planning quickly, confidently and logically. So in a nutshell, the main issue here is that the topography cylinder is almost always different from the manifest cylinder, and how do we integrate both these cylinders to give the final correction to the patient. So to understand this, we need to understand from where does this cylinder come. So the manifest cylinder which the patient accepts is a combination of the anterior corneal cylinder, which is the topography cylinder, plus the astigmatism which is induced by higher order aberrations, which also comes from the anterior cornea, plus you have the posterior corneal astigmatism, and then you have the internal or lenticular astigmatism. So if we think logically, the manifest astigmatism is a vector addition of anterior cornea, higher order aberrations, posterior cornea and lens. Now we know the anterior cornea, we know the manifest, we can easily find out the posterior cornea. And if we use a vector calculator, if we manage to find the higher order aberrations somehow, then by vector mathematics we can calculate the lenticular astigmatism. And once we know the astigmatism from all components, we can incorporate all these into the final correction. So this is what I have done. I must admit, I'm not the first person to think on these lines. Dr. Mark Lobanoff has already done it with his software, but his software is currently only available in the United States and it doesn't work with certain devices. So just to show you how I plan a case using my software. So if this is our patient, you can see the manifest cylinder and the topography cylinder. If I open my software and show you, so it's a Microsoft Excel based software. So this is how it looks like, and I'll just play the software from. Okay, so this is how the screen of my software looks like. So if you can see, you can feed in all the basic data over here. And the software first gives you basic parameters like the ablation depth, residual stromal bed. It gives you the percentage tissue altered. It will tell you whether LASIK is safe or no. You can choose microkeratome and it will give you the ring, stop size of femto. And it will give you comments as to whether LASIK can be safely done or not. So this is the basic part. Now when I want to do Contoura planning, I go to the Contoura screen and you have to feed in the data here. Now there is an instruction manual how you calculate the higher order aberrations from the image that comes. I'm not going to go in the details of that, but once you follow the software protocols and fill in what we call as TALIS data for higher order aberrations, you can feed in the posterior corneal astigmatism. So if you don't have a device to measure posterior corneal astigmatism, you can use the software nomogram. The software also has a nomogram for PCA, or you can feed it manually. Then you click proceed. And once you click proceed, you get the individual components of astigmatism, that is cornea, the higher order, the internal astigmatism. And then when you click proceed, you get the final refraction considering all these things. And it also includes the nomogram, it also includes the spherical aberration compensation. So this is what the software does. And just to conclude, I would like to say that topography guided LASIK is basically the most advanced form of keratorefractive surgery today. Contoura LASIK is FDA approved, If it is done the right way using a software, you can do it in 100% of cases. You can do it in a very scientific and logical way, and you can see the actual benefits of topography guided LASIK over conventional LASIK.
Thank you, Dr. Zain. Dr. Sonu, your comments, please.
Zain, that's a very nice presentation and a very innovative software. I just want to know how different is it from the 4 series calculator?
There are few things which are different, sir. For example, 4CDs will not work without inputting posterior corneal astigmatism data. So in my software, you don't need to use that. You can just use the inbuilt nomogram. Besides that, it is pretty similar actually to the 4CDs. It's inspired from the 4CDs. But I have my own nomogram which I have used how much lenticular astigmatism to consider and all. I've done 100 plus eyes using it.
So do you think if I use an abarometer to calculate out those talus zones and calculate out what is the HOA at those levels, is it almost equivalent to,
I wouldn't say so, sir, because see, aberrometry can be very different in all machines, and we need to use the ones which are from the topolyzer itself. So probably another aberrometer like iTrace may give you something variable. So in order to get the maximum benefit, you need to use it. Unfortunately, Alcon has not given us a software to analyze the aberrations from this itself. That's why we need another software to do that.
So have you judged that this gives you a little more PTA than the average? I mean, since you're treating, you're taking more cornea now.
Yeah, it does. It depends on the aberrations. So aberrations are more maybe 10, 20 microns.
And do you still advise that you're treating the internal noise at the level of the cornea? Because you're treating
Sir, we have to. I would say we have to, because in some cases it is so much that if you just treat the cornea, you at least need to know. So in many cases, it may not be significant. But the cases where it is significant, it needs to be treated. If not, then you'll land up with a refractive.
Then there is a certain subset of population where you have the lenticular astigmatism and noise at the lens level, and you're still treating the cornea.
Sir, but we are not treating the entire lens. We are treating just that much that it is enough to compensate post-operatively.
Once these patients are then taken for cataract surgery, you're trying to unmask them.
By then, sir, the lens is itself, it has become stiff enough and it will not work. So if we treat half the lenticular astigmatism is what what I have come up with, it is enough that the patients can relax the other half themselves, but you are not treating the entire.
Thank you.
Yeah, thank you.
Nice.
Have you done a randomized study where one side you've done only topo laser, which is directly FDA approved, and the other side your formula, and how much is significantly different in clinical outcome?
Sir, the trials are ongoing. We are doing it from multiple centers in Mumbai actually. But honestly, it is a little difficult to get it unless you have a very big subset of population. Because 50 to 60% patients actually would work well with both. It is the remaining 30 to 40% patients who actually need it, and we don't see that many of those. The idea of this is you can do it logically without having to think. So if I see a patient in my OPD who's got a lot of higher order aberrations, I get happy because I know he's going to do well as compared to someone who has lower.
So have you checked that the astigmatism that you're treating with the software is greatly different from what you would personally factor in had you not used the software?
We do it for all patients. So that's what I'm saying. When the astigmatism is greatly different, the result of the software is better because that is when inaccuracy by using only the corneal astigmatism increases. So if I would see that the difference is very large in terms of magnitude and axis, those patients actually do much better post-op than in those in which it is similar. So if the astigmatism of cornea and the manifest is similar, they would do well even with a normal procedure. But in those which is different, they do even much better. So their vision is even better. This is preliminary judgment.
Yeah, so there are surgeons who actually factor in by taking half of the
Yes,
astigmatism.
yeah, that is the protocol by the company itself to do half, but that is not very logical because you're not taking case by case. You're just giving a standard approach for this. Here we are taking case by case, analyzing everything and customizing it. So some cases you will get the final refraction close to the manifest. Some cases you will get it close to the topo. Some cases you will get it in between. So it all depends.
Thank you, Dr. Zain. Please collect your certificate from Dr. Sonu.
Yes, sir, it's available right
Dr.
now for your
Avdesh?
cost.
Is Dr. Avdesh ready? Yeah. Thank you, Dr. Zain.